Hello and welcome to Insight Ophthalmology. I am Dr. Amrit, welcoming you to another comprehensive lecture. Today we are going to talk about in detail the anatomy of limbus. So what is limbus? The term limbus basically denotes a border between two different types of tissues. And when we talk about the limbus of the eye, we are basically referring to a border zone between the cornea and the sclera. Now, why is this limbus important? Despite its small size, the limbus actually excites our interest because it demarcates the optical clear cornea from the conjunctiva and opaque sclera. It also maintains nourishment to the peripheral cornea. Now, we know that our cornea is basically avascular and the limbus is highly vascular, and therefore, through the limbus, the peripheral part of the cornea receives its nourishment. As you go ahead in the video, you will know that the limbus actually is a site for, and it actually contains the pathway for aqueous drainage internally. It is also a site for various incisions in the cataract and glaucoma surgeries, and this is actually going to be the highlight of this lecture today. The limbus also consists of the palisades of Vogt, which actually harbor these stem cells, right? So, like any geographical border zone around the earthly globe, there is no uniform agreement about the precise boundary lines of the limbus as well. It is actually a very busy place and often quite confusing, and therefore, we brought out this video for you. So, well, then, in this video, we shall be talking about the gross anatomy of the limbus with important clinical nuggets. We shall try to understand the limbal zone not just from outside but also from inside. We will understand the term anatomical limbus, the histology of the limbus, the various external landmarks of the limbus, what is meant by surgical limbus, and what is the relationship between various limbal incisions and the structures of the anterior chamber angle. Okay, so let's get started. I hope you will like this video. So, externally, if you have a look at the limbus, it is basically formed by the junction between the corneal epithelium and the conjunctival epithelium. So, actually speaking, it is a gradual transition at the limbus from the stratified non-keratinized columnar epithelium of the conjunctiva to the stratified non-keratinized squamous epithelium of the cornea. And if you observe carefully, the limbus is actually about 7 to 10 cell layers thick. Okay, now the limbal epithelium, if you observe carefully here, is actually thrown into these various folds with intervening tissues of subconjunctiva. Okay, so the cells which are present at the basal part of the epithelium or in the basal layers of the epithelium of the limbus, they seem to be actually stacked on one top of each other. Right now, this stacking pattern of the cells is known as palisades, and in limbus, this is known as the palisades of Vogt. Right now, another important point to remember over here is that the presence of palisades of Vogt and their quantity is quite inconsistent, and it varies from one person to another. Right now, the palisades of Vogt, they are important because they actually contain the corneal stem cells which have regenerative capacities and they help in the corneal wound healing processes. The palisades also consist of some amount of pigmented cells which are known as the melanocytes, and these melanocytes are actually responsible for the brownish appearance of the palisades that you see in the second picture over here. In our video on the anatomy of cornea, we already discussed about the XYZ hypothesis of the limbal cell proliferation. But for your benefit, I shall summarize that now. The cells basically are proliferating in this crypts, okay? And as they start proliferating from the basal layer, they start stacking on top of each other, and this stratification of the basal cells on top of each other basically is said to happen along the x-axis. Now, after they have multiplied, these cells will start migrating centripetally towards the cornea, and this happens along the y-axis. And now, as the cells start growing, moving centripetally and stacking on top of each other, the older cells basically will start to slough basically from the cornea into the tear film, and this actually happens along the z-axis. Okay, so that is your XYZ hypothesis of corneal cell proliferation. Now, before we understand the anatomy of limbus in detail, it is very important to understand the concept of scleral and conjunctival overlap over the cornea. Okay. So first let us try to understand this diagram here, because using this diagram I'm going to try to explain the various landmarks of the limbus as well. When seen from outside, the limbus seems to be basically the junction between the epithelium, between the corneal epithelium and the conjunctival epithelium that you can see over here, right? So this is the conjunctival epithelium, this is the corneal epithelium, and the limbus is basically the junction over here. You can actually note that the conjunctival epithelium is actually overlapping the cornea. So the cornea is up till here, whereas the corneal epithelium is only till this level, and the conjunctiva along with the substantia propria, that is the subconjunctival tissue, is actually overlapping your cornea considerably, right? So that marked over here is the substantia propria. So there the grey color part is the sclera, this is the cornea. The sclera basically forms an internal groove, okay, and this internal groove is known as the scleral sulcus. Now the scleral sulcus ends posteriorly with this spur or projection which is called the scleral spur. Now the sulcus is basically covered by this green color triangular tissue in this cross section, okay, so that is your trabecular meshwork, and external to the trabecular meshwork is your Schlemm's canal, right? So the trabecular meshwork basically covers your scleral sulcus and converts it into a Schlemm's canal. So that is important. Now let us go further inside and try to understand the limbus from inside. Before that, you can observe over here this yellowish line. So that yellowish line is nothing but it is the Bowman's membrane. So I hope by now everyone knows what are the layers of cornea. If not, I'm going to provide the link to anatomy of cornea in the description box. Now, we know that the epithelium basically sits on the basement membrane, which is known as the Bowman's membrane. And this over here in yellow color is the Bowman's membrane. Then we have the stroma, and then we have the Descemet's membrane. The termination or the prominent posterior end of the Descemet membrane basically in the cornea is actually known as the Schwalbe's line, right? Then you can see from there what is beginning. This is the trabecular meshwork, right? And it is very important to note that the corneal endothelium does not continue over the trabecular meshwork. So that is very important point, and that also brings you to a clinical nugget that we'll discuss is that during the embryological development, the trabecular meshwork is also covered by the endothelial layer, which is confluent with the corneal endothelium. It is only at the in the later stages of the third trimester when this membrane starts retracting back towards the cornea. Okay, now what really prevents the corneal endothelium respect this border is not really understood, but occasionally what happens is that the corneal endothelium will actually start to grow towards the trabecular meshwork, and then what happens is this endothelial cells of the corneal endothelium which are growing on the trabecular meshwork, they basically are replaced with a more epithelial like cells, and these epithelial like cells have this migratory characteristics. They start migrating towards the trabecular meshwork, and they don't just limit to trabecular meshwork, they also migrate on the surface of the iris, right? Apart from that, they have these contractile properties. So now when they're going to contract, it will lead to formation of the holes in the iris. It will actually pull the iris forward and closing this angle, leading to the synechiae formation. This is called peripheral anterior synechiae, and ultimately it can lead to the secondary angle closure glaucoma, right? So proliferation of these similar endothelial cells has been described in the iridocorneal endothelial syndromes, also known as the eye syndromes. It is also seen after trabecular trauma, and it is also seen sometimes after the laser trabeculoplasty. Let us talk about a very important topic of discussion, and that is the difference between the anatomical limbus and the surgical limbus. Okay, so first let us talk about the anatomical limbus. The pathologists basically define the anatomical limbus as a block of tissue which is bordered anteriorly by a line joining the peripheral extremes of the Bowman's membrane and the Descemet's membrane. So as you can see over here, drawn in orange color is your Bowman's, and drawn in green color is your Descemet's membrane, right? So a line joining these two will form the anterior border of the anatomical limbus. And the posterior border of the anatomical limbus will be basically formed by a line which is drawn from the scleral spur, and this line should be perpendicular to a tangent which is drawn at the external surface of the globe. Okay, now this makes the limbus basically an oblique transition zone, right? Now, if you carefully observe these two pictures, you can see that externally the width of the limbus is different in these two pictures. So what I'm trying to convey with these diagrams is that we know that the conjunctiva basically overlaps your cornea to a significant extent, and at the termination of the conjunctival epithelial overlap, the Bowman's membrane basically is terminated, right? Now, what exactly happens at 12 o'clock and at 6 o'clock meridians, that is at the vertical meridians of the eye? What happens is that the conjunctiva extends more anteriorly over the cornea, leading to an earlier termination of the Bowman's membrane. Now, since the Bowman's membrane is ending prematurely in the upper and the lower quadrant of the eye, therefore, the border of the cornea, the width of the limbus is also more in the upper and in the lower quadrant of the eye. Okay, so in the upper border, that is 12 o'clock and 6 o'clock, the limbus is broader compared to the nasal side and the temporal side, that is in the horizontal meridian. Now let us talk about the histology of the limbus. Now at this point, I would like to tell you about the various changes that occur at the limbus. The first change occurs with respect to the epithelium. We know that the corneal epithelium is basically stratified, non-keratinized, squamous epithelium. That epithelium changes to the columnar, stratified, non-keratinized conjunctival epithelium. What about the Bowman's membrane, which is sitting right next or below the corneal epithelium? The Bowman's membrane will basically terminate at the limbus. What about the substantia propria? The substantia propria of the conjunctiva over here, you can see, it is basically fusing with the conjunctiva. It is fusing with the episclera and the tenons capsule, right? So substantia propria fuses with the episclera, tenons and conjunctiva at the limbus, and this actually provides a very firm grip if you hold the eyeball using your forceps during the surgery, right? So it helps in stabilization of the globe. Apart from that, the regular corneal collagen fibers which are present in the stroma of the cornea, they change into the irregularly arranged scleral collagen fibers. The Descemet membrane is also going to terminate over here, and the end of the Descemet membrane in the cornea is known as the Schwalbe's line. The corneal endothelium also terminates over here, and at the limbus now it reaches the trabecular meshwork and it basically wraps around the trabecular meshwork beams. Okay, so what I'm trying to tell you over here is that the corneal endothelium does not blindly covers the trabecular meshwork, because if it does that, there will be no filtration occurring through the trabecular meshwork, right? Instead, the endothelium is going to wrap around those perforations or the beams that we have in the trabecular meshwork. A little bit more about the collagen fibers. So in the cornea, the fiber size is less. It is about 700 angstroms. The fibers are regularly arranged, and because of this regular arrangement, we basically get that blue appearance of the cornea or the transparent appearance of the cornea. Whereas if you look at the sclera basically has collagen fibers which are about 700 to 1000 angstroms, and they are irregularly arranged, and this makes the sclera basically opaque. Again, one more point that I would like you to observe is that the scleral fibers are actually extending more anteriorly on the external side compared to the internal side of the limbus. That means the sclera is basically also overlapping the cornea along with the conjunctiva. Now, if you look at the interface between the sclera and the cornea, it is not a straight line. Instead, it is actually forming this curvilinear diagonal because of the considerable overlap of the sclera over the cornea, right? And the importance of this curvilinear diagonal is that because of the curvilinear diagonal, you have these zones where the cornea and the sclera coexist, and there will be a differential scattering of light that occurs because of this overlap, because of the presence of the curvilinear diagonal interface between the cornea and the sclera, and this is something which is responsible for the appearance of the surgical limbus. So we'll talk about the surgical limbus in a while, right? The same can be observed here as well on the anterior segment OCT. You can see that This is actually your cornea. The corneal lamellae being regularly arranged, they do not reflect the light much and therefore they appear hyporeflective compared to the sclera. And this over here, the whitish part is actually the sclera. And over here, this is the iris, right? So you can see this exactly here, this line which is ending is basically a Schwalbe's line. However, the most consistent landmark that you find on anterior segment OCT is basically your scleral spur. So you have to trace, basically this is the iris and this is where the sclera is actually changing its curvature. So this is your scleral spur, and from the scleral spur then you can actually trace your other structures at the angle, example your trabecular meshwork. So trabecular meshwork basically looks like a triangular structure anterior to the scleral spur on the anterior segment OCT, right? So moving ahead, let's talk about the cells at the limbus. The important cells of the limbus are basically present at the palisades of Vogt that we discussed, and also they are located in the anterior part of the trabecular meshwork. So over here, somewhere here, you have some important cells residing. Now these cells, the trabecular cells which are present in the anterior part, almost about 60% of the newly dividing cells are concentrated in this most anterior region of the trabecular meshwork, right? These cells actually have a phagocytic capability, and in fact they can actually detach themselves from the trabecular beams in a very macrophage like manner whenever the eyeball is exposed to foreign material, right? Or whenever the trabecular meshwork is exposed to foreign material, right? Now as they basically detach themselves from the trabecular beams, this denudation of the trabecular beam actually is a contributor to the outflow obstruction that occurs in some form of glaucoma. Now these denudation of the cells, or this detachment of the trabecular cells and their converting into phagocytic cells, has also been seen post laser trabeculoplasty. So post laser trabeculoplasty, it has been seen that these cells will basically detach themselves and they will become phagocytic, and then these dividing cells will migrate to the laser burned areas, right? So that is one important point that you must remember. So now let us talk about the surgical limbus. So what exactly is surgical limbus? So don't worry, we will be talking in detail about the surgical limbus when we talk about the limbal boundaries and landmarks in a while. But to make things easier, as you can see in the first picture, we have this blue zone which is present all around the cornea. Okay, now this blue zone which is present around the cornea is known as the surgical limbus. Okay, now we know that the cornea is also it has some amount of conjunctival overlap, right? Now, because of that conjunctiva present over the cornea, sometimes it becomes very difficult to appreciate this blue zone. But in most of the cases, after you do the peritomy, that is the reflection of the conjunctiva from the cornea, the blue zone becomes quite appreciable. Okay. The second picture is that of a trab, and that is something that I'll explain to you in a while. Now, what about the limbal boundaries and landmarks? Okay, so to understand that, let us take this diagram. So you can clearly observe that we basically have this zone over here around the cornea, which is called the blue zone, and which can also be called as the surgical limbus. Right now, around that blue zone, you can see another zone, and this zone is known as the white zone. Now, what are the boundaries of these zones? So, just at the junction over here of the cornea and the blue zone, you have the anterior limbal border. Then you have another line over here between the blue zone and the white zone, which is referred to as the mid-limbal line. Now, some people like to call it as the posterior border of the surgical limbus, right? It quite makes sense because the blue zone is also a surgical limbus. So, some people try to call it as the posterior border of the surgical limbus, okay? But here we would like to call it a mid-limbal line. Then we have the posterior limbal border, which is the posterior limit of the white zone. So in this diagram, you can actually observe this blue limbal zone. Okay, so this is the blue limbal zone. Then over here, you can observe that actually the phenomena of sclerotic scatter. So if you don't know what is sclerotic scatter, we have a video on the slit lamp examination technique. So I will put down the link in the comment section or maybe in the description box. Okay, so you can check that out. So the sclerotic scatter is important because it helps us in seeing the white zone. Okay, so the blue zone is quite visible as you can see over here, but the white zone is difficult to appreciate because the sclera itself is white in color, right? So if you carry out these sclerotic scatter, the posterior limit of the sclerotic scatter basically forms the posterior end of your white zone. Okay, so using sclerotic scatter, one can actually appreciate the white zone of the limbus. Now, Kastner basically popularized the correlation between these external landmarks of the limbus and the internal structures of the angle. And understanding these landmarks is immensely important because it helps the surgeon in planning the incision during various types of intraocular surgeries. Okay, so let us see how. So over here we have the anterior limbal border, and you can see that the anterior limbal border basically corresponds with the termination of the Bowman's membrane. The mid-limbal border, which is the posterior part of the surgical limbus, basically correlates with the termination of the Descemet's membrane. Now, at this point, we can say that the blue zone, which is over here, is basically a zone which is formed by the termination of the Bowman's membrane and the termination of the Descemet membrane, and is basically consisting of what? It is consisting of the cornea. And as you reach the Descemet membrane, as you go posterior part of your blue zone, you have slight amount of overlap by the sclera as well. Then the posterior limit of the white zone or the posterior limbal border is basically corresponding to the scleral spur. Okay, so you might want to pause the video over here and put these points in your head clearly. Okay, you might want to repeat it, that the anterior limbal border corresponds with the termination of the Bowman's membrane. The mid-limbal line corresponds with the termination of the Descemet membrane, and the posterior limbal border or the posterior limit of the sclerotic scatter basically corresponds roughly with the scleral spur. Okay, so again in this picture, after you can see that in the first picture there's cataract and probably the patient is undergoing cataract surgery. After the limbal peritomy, you can see that this is the blue limbal zone over here. Okay, so the blue limbal zone is basically a bluish translucent zone between the anterior limbal border and the mid limbal line. So this is the anterior limbal border, this is the mid limbal line. Okay, and this corresponds to the part of the cornea between the termination of the Bowman's membrane and the Descemet membranes, as I explained to you. Okay, it can be seen after the conjunctiva and tenons have been reflected after a peritomy. Okay, now the extent of blue zone is basically quite variable. It's variable because of the variable overlap of the cornea with the conjunctiva, as I explained to you previously. Okay, so the blue limbal zone in the superior quadrant is about 1 millimeter. In the inferior quadrant is about 0.8 millimeters. In the temporal and in the nasal quadrants, it is about 0.4 millimeters. And it is very important for you to know that the blue zone is nothing but your surgical limbus. Okay, so this diagram actually represents the various extents of the blue limbal zone in different quadrants. So you can see superiorly the limbal zone is broader. The question is, why do you see surgical limbus as blue in color? As I told you, the interface between the cornea and the sclera is not straight. Instead, it's curvilinear diagonal, and that causes a differential scattering of light through that oblique interface, leading to giving it an appearance of bluish, grayish or bluish translucent appearance, right? Now, the first picture is that of a trabeculectomy surgery. So you can see over here that a scleral flap is basically being made, and as the flap is basically everted, you can see the blue part or the blue zone more clearly, right? Now, basically, why is this happening? We know that there's a considerable amount of scleral overlap over the cornea, right? And in this surgery, as you're actually raising this flap, you are raising the scleral flap, the blue cornea which is underneath is becoming more apparent or visible, right? And this is exactly the diagrammatic representation of the same. So you can see the flap has been raised and the blue zone becomes more prominent here. So this is your blue zone about 1 mm, and that is the white zone about another 1 mm. Now, it's very important to understand the relationship between the limbal incisions and the structures that you're going to cut in the anterior chamber angle. Okay, so let us try to understand them. First, let us talk about the incision at the anterior limbal border. Okay, so when the incision is given at the anterior limbal border, that means that you are basically trying to give the incision at the end of the Bowman's membrane over here, right? That means if you continue that incision, you will enter your anterior chamber, and this incision will be quite anterior to the termination of the Descemet membrane, which is over here, and you are going to pass straight into the anterior chamber, passing through your Descemet's membrane, right? So I hope that is clear. Now, since the incision is actually passing through the descemet membrane, there is actually a risk of descemet membrane stripping and detachment, and this basically applies to all the incisions that are actually taken at the anterior limbal border, or even the incisions which are taken in the blue zone. Okay, the reason is because even if you take an incision, say this is the point, this is called the mid limbal line or the posterior border of your blue zone, right? We know that corresponds to the end of the descemet membrane, right? So ideally speaking, this is Bowman, this is descemet's ending, and this is your blue zone. So anywhere here, if you take an incision, you are passing through the descemet's membrane, and there's a risk of descemet's detachment, right? So these incisions are called as the anterior limbal incisions, which are basically taken within the blue zone. Now let us talk about another incision, and this incision is taken at the mid-limbal line. So this is called a mid-limbal line incision, or an incision at the posterior border of the surgical limbus. Here also, when you take an incision, you will enter the anterior chamber. So this is the anterior chamber which is present between the cornea and the iris. Okay, and here the entry is actually through the ending of the descemet's membrane. However, this entry you can see is anterior to all the angle structures. So this is your trabecular meshwork, the Schlemm's canal. So when you enter like this, all the structures of the angle are basically posterior. As a matter of fact, the Schlemm's canal is about 0.5 millimeters from this mid-limbal line. And since the structures are posterior to your incision, this entry is actually considered a safe entry into the anterior chamber, right? So that is your mid-limbal line incision, or a posterior border of the surgical limbus. Now, what about if we take an incision at the posterior limbal border, or the posterior limit of the sclerotic scatter? Here, don't get confused between the posterior border of the surgical limbus and the posterior limbal border, which is the posterior limit of the sclerotic scatter. Okay, so here we're trying to talk about the posterior limit of the white zone, which is the posterior limit of the sclerotic scatter as well. So since I told you that posterior limit of the sclerotic scatter basically corresponds roughly to your scleral spur, and when you actually cut internal, when you actually give an incision here, you are somewhere opening at the scleral spur and sometimes even behind it, and in such a condition you will not actually enter your anterior chamber, and instead you will enter the supraciliary space, okay, which is located about 0.5 millimeters behind the scleral spur. Okay, so that is something which is very important, that at the posterior limit of the sclerotic scatter, if you take an incision and make an entry into the eye, you will enter the supraciliary space, which is a space located above your ciliary body. Now, at this point, I would like to ask you what is meant by a clear corneal incision. Okay, so as you can see over here, the incision is actually given anterior to the anterior limbal border. So this is your anterior limbal border. Okay, and if the incision is given anterior to the anterior limbal border, that is called a clear corneal incision. Something what you can see over here in this surgery, the blade is being entered somewhere here. Okay, so this is actually your phaco incision. So phaco incisions are usually clear corneal. That means you are entering anterior to your termination of the Bowman's membrane, right? The only problem with these incisions is that if not performed carefully, there's a greater risk of descemet's detachment, and also they induce high amount of astigmatism because the incision is right away into the cornea. Now, as a rule, the more anterior the incision is, the more chances of getting astigmatism. The more posterior an incision is, there are more chances of bleeding, but less chances of astigmatism. Now, what about the wide zone incision? So here I'm trying to talk about an incision which is taken between the mid-limbal line and the posterior limit of the sclerotic scatter. So the mid-limbal line corresponds to your descemets, and the posterior limit of the sclerotic scatter corresponds to your scleral spur. So in between that is your wide zone. So if you take an incision at this level, basically you are going to enter the trabecular mesh, you are going to basically enter the anterior chamber, passing through the trabecular meshwork, right? So wide zone incision will basically cut through the trabecular meshwork into the anterior chamber. So I hope that is clear. Now, there are another important landmarks also in relation to the surgical limbus that you must remember. Surgical limbus is nothing but your blue zone, and it is basically bordered by the anterior limbal line and the mid limbal line, right? Now, first let's talk about the root of the iris. So, root of the iris is nothing but where the iris attaches to your sclera. The root of iris is basically situated at a distance of about 1.5 millimeters from the surgical limbus. So, your surgical limbus will be somewhere here. So that is about 1.5 millimeters. So if you have an iridodialysis and you want to repair an iridodialysis, okay, then in those cases the suture has to be, the iris basically has to be sutured at a distance of about 1.5 millimeters from the blue limbal zone, right? So you can see over here, because the root of the iris is 1.5 millimeters. So this is an iridodialysis. You can see a suture, double arm suture, has been passed through the iris and it has been sutured under a flap onto the sclera at a distance of about 1.5 millimeters. So that is one important landmark that you must remember. Another important landmark is that of a ciliary sulcus. First, you should know what is meant by a ciliary sulcus. The ciliary sulcus is basically a space between the iris and the pars plicator part of the ciliary body. So this groove over here is known as the ciliary sulcus. This illustration is that of an ab interno IOL fixation. The IOL is basically being fixated with the sclera. So you can see that the haptics are tied with the sutures and then the sutures are being brought out from inside to outward direction, and that's why it is known as an ab interno scleral fixated IOL. Okay, now the question is that at how much distance from the limbus are you going to bring your needle or your sutures out so that the IOL is nicely secured in the ciliary sulcus, right? Now this was actually answered by this paper. I would actually give the link in the description box. Now this paper actually suggested that whenever you're carrying out an ab interno ciliary sulcus fixation, the suture which is fixing the IOL, and if you're using a straight needle, the needle basically should emerge around at a distance of about 2.5 millimeters from the mid-limbal line or the posterior surgical limbus. Now this paper actually suggested that although the ciliary sulcus, which is here, it is located at a distance of about 0.4 to 0.5 millimeters, and the width of the pars plicator is another 2 millimeters. Okay, so it is, you might actually think that you will just insert the needle over here, but no, that doesn't happen because this is quite a vascular area. You don't want to damage the delicate vasculature which is present here and cause bleeding. Instead, what we do is we basically use a straight needle and the needle basically comes out through the ciliary sulcus like this. Okay, so as the needle comes out from the ciliary sulcus traveling through the sclera and out of the sclera, the distance between the limbus and the emergence of the suture or the needle when using a straight needle is about 2 to 2.5 millimeters from the mid-limbal line or the posterior surgical line. Okay, so that is one very important thing that you must remember. And if the suture is being tied or if the IOL is being fixated using the pars plana route, the pars plana is situated at a distance of about 3 millimeters from the posterior surgical limbus, right? Now over here there's quite some disparity. Some books say that it is 1 to 1.5. However, I found that in the article and what I have learned at my institute, it was 2 to 2.5 millimeters. So do comment in the comment section and tell me what do you follow at your institutes. Okay, the distance of the ciliary sulcus from the posterior surgical limbus, right? So basically, to summarize, if you take an incision at the anterior limbal border, you will be basically entering through at the end of the Bowman's membrane through the descemet into the anterior chamber. If you take an incision at the mid-limbal line, you will be entering again the AC, but here you have the termination of the descemet's membrane. Chances of descemet stripping are more in these cases. The angle structures are obviously located in the white limbal zone, that means behind the mid-limbal line or behind the blue zone. And if you make an incision at the posterior limit of the sclerotic scatter, you will insert your needle, insert your incision or blade basically at the scleral spur or near the scleral spur, and in this case you will basically be entering your supraciliary space and not the anterior chamber. Now, if you want to carry out the iris repair, iris dialysis repair or iridodialysis repair, that is done at a distance of about 1.5 millimeters from the mid-limbal line. If you want to enter this space, which is the ciliary sulcus, using a straight needle, the distance will be 2 to 2.5 millimeters. And if you are carrying out a pars plana fixation of the IOL, that will be about 3 millimeters from the mid-limbal line. Okay, so that was all for today. I hope it was useful. Thank you and have a nice day. If you liked our content, make sure to subscribe to our YouTube channel. Also, you can actually join our YouTube memberships, and I often get a question as to how do I join the membership. So let me demonstrate that to you now. In order to become a member of Insight Ophthalmology, first you need to watch any video of Insight Ophthalmology. For example, right now I'm watching this video on Mastering Iris Anatomy. So here below the video, you will see there are two buttons. One is a join button and one is subscribe button. So make sure you're subscribed to the channels. Okay, so this is what happens when you subscribe to the channel. And after that, you can see that on the left hand side, there's a join button. So using this join button, you can actually join the memberships. So once you click on the button, you will be able to see that there are 3 levels of memberships which are available, and their perks are actually depicted on the right hand side of the dialog box. So you can choose the membership which is best fit for you, and once you actually choose it, you can click on the join button and then you can do the purchase according to the method which is best fit for you, right? So that's how you actually join these memberships. And often I get a question that people are not able to join memberships, they're not able to see join button over here. So the reason could be either you're not logged in, so make sure that you're logged in into your YouTube account. And the second thing that you need to make sure is that sometimes the YouTube memberships might not be available in your country because of some security reasons and because of some private policies of YouTube and the government in your country, right? So in those cases, I also cannot help you. I really apologize that I'm not able to help you in that case, right? And for the rest of you who are lucky to see this join button, you can go ahead and click on it. And that's all. I hope it was useful. Thank you and have a nice day.